All right, pathogenesis and disease classifications. The progression of periodontal disease. So, what is pathogenesis? It's the originating cause of disease. All right, so pathogenesis is the sequence of events that occur that develop a disease, like we talked about. Periodontal disease is a bacterial infection of the periodontium. There are two types of periodontal disease, gingivitis and periodontitis. Now remember, periodontal disease and periodontitis are two different things. Periodontal disease is diseases that affect the periodontium. Periodontitis is inflammation, the disease of inflammation of the periodontium. All right, basic infection of the periodontium, pathogenesis. Bacteria byproducts enter the gingiva, and they create a host immune inflammatory response. Antigens and LPS, or lipopolysaccharides, enter the tissue. And then PMNs, or neutrophils, respond and set off chemical communication. And then more chemicals are released. And the most important ones are cytokines, such as interleukin-1, prostaglandins, or PGE, and MMPs. Okay? Gingivitis. Gingivitis is a bacterial infection that is confined in the gingiva. It's not in the bone. Gingivitis is reversible destruction of the tissues of the periodontium. Okay? Now, periodontitis is a bacterial infection of all parts of the periodontium, not just the gingiva. So, this includes the gingiva, PDL, bone, and cementum. Periodontitis is not reversible. It's irreversible in tissue damage. Once it's damaged forever. All right. 3 basic states of the periodontium. So you can have health, gingivitis, periodontitis. Basic states of the periodontium. So the periodontium and health. Healthy mouths have pink, firm gingiva that isn't bleeding. Healthy sulcus, the junctional epithelium is coronal to the CEJ. Supragingival fibers intact, alveolar bone intact, PDL intact. What's the number one indication of disease? Bleeding. So here's the healthy mouth. Healthy gingiva, pink and stippled, no bleeding, no inflammation. Reminder, junctional epithelium is coronal to the CEJ in health, which means you have the CEJ right here, cemento-enamel junction of the cementum and the enamel, and then you have junctional epithelium, and that's above the CEJ. So, CEJ, junctional epithelium, is above it, or coronal, towards the crown of the tooth. That's good, healthy. All right, the periodontium and disease. So, gingivitis, which again is reversible. It's the clinical picture would be red, swollen, most likely bleeding. Okay, that's gingivitis. Now, as far as the tissues, the junctional epithelium is directly on the CEJ. Okay, not coronal to it, not apical, but directly at the CEJ. There are some supragingival fibers destroyed, but alveolar bone's not hurt and PDL's not hurt. Okay, makes sense because in gingivitis, it's reversible. Doesn't affect the bone, just affects the gingiva. All right? So, here's a picture of gingivitis. Red, swollen, sometimes bleeding. Where's the first sign of inflammation going to show up? It's going to show up in the marginal gingiva because that's where the biofilm first touches the gingiva, right? Okay. So, more gingivitis, inflammation, bleeding, puffy gums, redness, shininess. For gingivitis, bleeding on probing is a primary diagnostic parameter. Gingivitis is observed clinically from 4 to 14 days after biofilm accumulates in the gingival sulcus. You can have acute gingivitis or chronic gingivitis. Acute gingivitis lasts for a short time. It's characterized by fluid in the gingival connective tissues, and tissues appear really swollen. Chronic gingivitis is just when it lasts for months or years. So again, on a histological view, in gingivitis, the junctional epithelium is directly at the CEJ, but not apical to it and not coronal to it. And the supragingival fibers are destroyed, but not the bone. So, progression of gingivitis. The tissue damage is reversible, but in many cases, it can turn into periodontitis, but sometimes it doesn't. Sometimes gingivitis lasts for years and we don't know why. Okay, now periodontitis. So remember, you have health, gingivitis, periodontitis. Periodontitis is permanent destruction, affecting the bone, PDL, gingiva, stuff like that. So, periodontitis, you can see pink or purplish tissues, swollen or fibrotic, and definitely bleeding. Junctional epithelium is on cementum. It's migrated apical to the CEJ. Supragingival fibers are destroyed, alveolar bone is destroyed, and PDL is destroyed. Okay? And the crestal bone has migrated apically. So, just to review, periodontitis, junctional epithelium is now apical to the CEJ, loss of connective tissue, loss of bone, and this is permanent damage. Perio is permanent. Here's a picture again. Junctional epithelium is below the CEJ. It's migrated apically. So here's a nice little chart showing us, again, a review. In health, junctional epithelium is coronal or above the CEJ, right? Junctional epithelium is above the CEJ. Gingivitis, junctional epithelium is at the CEJ. And periodontitis, junctional epithelium is below the CEJ. All right? So here's another great picture. In health, when you probe, you're probing directly where you should be probing, not deep down by the cementum in the bone. In gingivitis, you're probing a little bit deeper because the gingiva is inflamed, so there's more room to probe. And then periodontitis, you're probing way deeper, way past CEJ into the bone. All right. So let's talk about bone levels real quick. In a healthy mouth, the crest of the alveolar bone is 2 millimeters below the CEJ, right? It's normal to have 1 to 2 millimeters of bone loss in the CEJ because that's where the bone sits naturally in a healthy mouth. Okay. Gingivitis, the bone is still at 2 millimeters below CEJ. Junctional epithelium is also at its normal level in gingivitis. Beware of this tricky question. There is no bone loss in gingivitis. No bone loss in gingivitis. Crestal alveolar bone is still 2 millimeters apical to CEJ, where a normal healthy bone usually is. All right. Now, but in periodontitis, there is bone loss, right? And bone destruction, which leads to tooth loss. So now, bone loss is no longer 1 to 2 millimeters. It's way past that. So there's examples of that. Let's review a little bit of bone loss real quick. What's the difference between fenestration and dehiscence, or dehiscence, or whatever? Fenestration is when there's a hole in the bone, but you still see an alveolar ridge. So see right here, I'm looking at the tooth. The alveolar ridge is still horizontally across the tooth, but then if you move up, you can see the tooth root in a little hole of bone. Okay, that's fenestration. There's a fence with the hole in the fence. Okay, dehiscence. Dehiscence is a big U shape of bone loss. There's no alveolar ridge. Now you can just see where the bone is. All right, so there's fenestration, dehiscence. So what are the different types of bone loss? You can have horizontal or vertical. Horizontal is the most common pattern. It's even, overall reduction of bone. It's like if you took the bone and you just push it down with both hands. And then you have vertical bone loss, and this is less common. It's uneven. It means there's rapid regression of bone loss next to the root. It leaves a trench-like area of missing bone. So when you have occlusal disharmony or trauma, what type of bone loss are you going to have? Vertical bone loss, because again, it's localized to where that trauma is happening. So horizontal bone loss results in even amounts of reduction of bone. Vertical bone loss results in vertical triangle shapes of bone or a trench area, most often seen in occlusal disharmony. All right, pathways of inflammation into the bone. So horizontal bone loss begins in the gingiva, it migrates to alveolar bone, and then into the PDL, right? Nice and evenly. Vertical bone loss migrates into the gingiva, migrates directly into the PDL, and then into the alveolar bone. Does that make sense? So let's review that again. Horizontal bone loss, it goes gingiva, alveolar bone, PDL, like a normal, regular way, right? Gingiva, alveolar, PDL. Vertical bone loss, gingiva, PDL, alveolar. Okay? All right. Vertical bone loss again occurs when the crestal PDL fibers are weakened, and it's also associated with occlusal trauma. All right, and now you can have bone defects. So, bone defects are classified on the basis of the number of bony walls remaining. So, if you look at this picture, type A, picture A, you can see a tooth that has bone loss, but there's 3 walls of bone still touching the tooth. A wall on the facial, a wall on the mesial, and a wall on the lingual. But on the distal of this tooth, there's bone loss. So, that is called a 3 bony wall defect because there's 3 walls of bone touching the tooth. Now look at picture B. Now you only have the lingual and the mesial part of the tooth touching bone. Half of the facial and the distal are missing bone. So this is called a 2-wall defect. There's only 2 walls of bone remaining, okay? And then you have a 1-wall defect, where only 1 wall of bone is remaining. In this picture, picture C, the lingual, distal, and facial walls are missing. So just the mesial is there. So that's a 1 wall. These defects occur from vertical bone loss. You're not going to see these in horizontal, right? Because in horizontal, all the bone gets pushed down. In vertical, just areas and parts of the bone get pushed down. So again, we're going to look at big pictures of that. This is a 1-wall defect because 1 wall is missing. 2 walls are missing. 3 walls are missing. And then you also have interproximal osseous craters. And this is if bone loss goes between adjacent teeth. It's called an osseous crater, bone crater basically. All right. Furcation involvement. Infection invades the area between and around the roots, results in loss of alveolar bone, and you'll have furcations appear. So you have furcation in class 1 or grade 1, which is when you can feel around the tooth with the explorer, but you can't necessarily touch the little opening yet. Grade 2, you can feel around the furcation with the explorer, and you can push the explorer a little bit into the opening. Okay, you can catch on the opening. Grade 3, or class 3, is when you can push the explorer all the way through the furcation, in and out. Alright, so there's examples of furcations. Alright, now pockets. How do you form perial pockets? So, in the gingiva, there's a deepening of the gingival sulcus because of inflammation. The inflammation grows, right? So when you probe, the sulcus is deeper, but really it's because the gingiva is bigger, not because there's bone loss. There's no apical migration of the junctional epithelium. Junctional epithelium in gingivitis stays at the CEJ. It stays coronal to the CEJ. So in health and in gingivitis, junctional epithelium is coronal to CEJ. So these are called pseudopockets. They're fake pockets. Because really a pocket means there's bone loss, right? But in gingivitis, a fake pocket means that the gingiva is just inflamed, and so it looks like there's bone loss, but it's not. The pocket is bigger because the gingiva grew. Now, periodontal pockets. You have a pathologic deepening of the gingival sulcus. So you actually do have bone loss. The gingiva didn't grow, you just have bone loss because that's what happens in perio. So you have apical migration of the junctional epithelium, destruction of PDL ligaments, destruction of bone. So again, gingival pocket, seen in gingivitis. A coronal portion of junctional epithelium detaches from the tooth, resulting in a slight increase in probing. Tissue swelling also increases the probing. And then you have perio pockets. So for perio pockets, you can have a super bony pocket and an infra bony pocket. So in a perio pocket, a super bony pocket means there is horizontal bone loss. Junctional epithelium is located coronal to the crest of the alveolar bone, right? So look at the picture. Junctional epithelium is supra bony, or above the alveolar bone. Infrabony pockets, there is vertical bone loss. Junctional epithelium is apical the alveolar bone. So this type of pocket, the junctional epithelium is now breaking into the bone. Okay? All right, so that is part 1 of pathogenesis and disease classifications.